Diabetes insipidus is a lack of antidiuretic hormone or a lack of response to antidiuretic hormone. Antidiuretic hormone is produced in the hypothalamus and released from the posterior pituitary gland. ADH and prolactin are the only two hormones released from the posterior pituitary. In this schematic diagram of the loop of Henle, we can see water passing through the tubules in the urine. Usually, when you are dehydrated or hypovolemic, ADH acts to insert aquaporin 2 channels in the distal convoluted tubules and collecting ducts of the kidneys in order to reabsorb water. Increased water retention increases urine osmolality and blood volume, increasing blood pressure and making urine more concentrated. Common presentations of diabetes insipidus are polyuria, which is an increase in urine production, and polydipsia, which is increased thirst. There are two types of diabetes insipidus: cranial, meaning the problem originates from the brain, or nephrogenic, meaning the problem originates from the kidneys. In cranial DI, the hypothalamus does not produce sufficient ADH for the pituitary to release. This causes the kidneys to reabsorb less water, instead excreting more water, resulting in high volumes of low osmolality urine. This can be idiopathic but also secondary to brain tumours or neurosurgery. In nephrogenic DI, there is normal ADH production, however, the kidneys do not respond to the action of ADH, so again reabsorb less and excrete more water, resulting in high volumes of low osmolality urine. This condition can be inherited, but can also be secondary to lithium use to treat bipolar disorder, as well as electrolyte disturbances or renal disease. In order to diagnose DI, the water deprivation test is undertaken. This involves the patient avoiding any fluid for 8 hours, measuring the urine osmolality, administering a dose of desmopressin, which is a synthetic form of ADH, then measuring the urine osmolality once again. In someone without any ADH affecting disorders, urine osmolality after avoiding fluid should be high, as water would be reabsorbed, meaning urine would be concentrated. However, someone with DI wouldn't reabsorb water, making the urine osmolality low even after depriving themselves of fluid. This is what causes the polydipsia. This allows us to also differentiate between cranial and nephrogenic DI, as after receiving desmopressin, someone with cranial DI would be able to reabsorb water as their kidneys respond to it. However, with nephrogenic DI, the urine osmolality would remain low as the kidneys don't respond to the desmopressin. Diabetes insipidus can be managed by desmopressin. In cranial DI, it replaces the unproduced ADH. In nephrogenic DI, it must be given in very high doses due to the very low sensitivity of the kidneys to ADH. However, this needs to be monitored very carefully.